Recording just a moment. Okay, welcome to Bioscience. It's lecture number 12. And today we have very important topics that are going to be seen in other modules. So we are going to touch the base of touch the basic things of these organs, and I'm going to give you extra. So always it's going to be your participation. Very welcome. If you participate, we can discuss more in deep. Okay, more in depth. All right. So let's get started. So if we talk about the eye, the eye, these are all the components of the eye. So I'm going to try to make it. All right, so listen, we have three areas that we need to remember. Three areas. The tunics, or the layers of the eye. We have the humors, and are actually the liquids of the eye. And other structures that cannot be classified as liquid layers are going to be the lens. The lens. Right? So we have all these structures. Lens is the same to say crystalline. Humor are fluid, aqueous humor and vitreous body. Humor vitreous is called better vitreous body. I forgot to correct that. So most common, either way, is humor vitreous or vitreous body. The important thing is that they contain vitreous, the word, okay? Vitreous. Either way is the same. Then we have the fibrous tissue that represent the sclera and the cornea. We have the vascular, the choroid, ciliary body contain the ciliary vessels, and the iris. We have sensory, we have the pigmentation that are the receptors, the rods and the cones, and the neural layer that is specifically the retina. So those are all the components that we are going to learn today. I want you to think about how much do we know about an eye at this moment. Okay, and how much we are going to see. Eye is a spherical structure filled with gel-like fluid. Cornea, a layer, I'm not going to read, of course not. So let's go to the picture to make it more dynamic. All right, so tell me one thing, everybody, please participate. How many letters we have on the word eye?
Three.
Three letters, right? So please, everybody, please, okay? If you say something that is going to stick in your mind more easily. If you have a word, whatever word we are talking, if you don't say it even once because everything is in your mind without saying, you are losing a tool that repeating a word with your ears, the sound, repeating with the word and listen with your ear, that is another way. If you use as many senses in order to learn things, is the best way to learn. All right, so the I have three letters. For three letters, I want you to remember that I is divided in three chambers. Three chambers. And
What slide number is this? Because I can't find it on the PowerPoint. 13.
No, it's actually went to the who's talking? Who's saying?
Julia.
Yeah, look the picture. I'm going to the picture and then I go back to the first slide.
Oh,
okay. Go to the picture. Okay. All right.
Okay.
All right. So we have three letters. We have three chambers and three layers. Don't forget that, please. Okay. Three chambers and three layers. Let's start with the layers. The layers are going to be three layers. One is what I'm going to draw here, paint here. Can you see this area? This is the outer layer. And this outer layer here, all this outer layer, is going to be called the sclera. Where is the sclera? Here, the sclera. Okay, again, sclera. This sclera is, write down this, is the white area of your eye. The white area of your eye. This sclera is a fibrous tissue that are going to help to keep the shape of the eye, the shape of the eye. If you dissect an eye someday, you will see that the sclera is going to be like a thick, very thick skin. It's similar of the skin of the grape. If you take the grape out, the pulp, and you take the the skin, if you touch it between fingers, it's double or triple more thicker. But it's basically the consistency of the sclera when it's without fluid, just the sclera in between your fingers. All right, so this sclera is the white area. So it's actually going to help to keep the shape of the eye. Okay? Please, I want you to think about the eye as a three-dimensional. So I cannot give you a three-dimensional because this is a bidimensional image. So try to imagine that you are inside of the sphere, and the wall outside of the wall is called the sclera. That is the white. So it's 360 degrees, all the sclera. The sclera then are going to continue anteriorly. This is anterior and this is posterior, right? When they go anteriorly, they are going to change. So up to here is the sclera. Up to here is the sclera, all what I just draw in red. So after that, it's going to continue. See, listen what I said. The sclera is the continuation of the sclera will be the cornea. Cornea. Cornea is the continuation of the sclera. Okay, it's not a different structure. So the cornea is the continuation of the sclera. So what is the difference between the sclera that is white, solid white, and the cornea? The cornea is going to be transparent. It's going to be basically clear. It's not going to be like a glass. So that is actually the cornea. This is the cornea. The cornea is the most anterior portion of the eye. You okay with that?
Yes.
All right, so for this, I don't do less in the morning, so I want just to remember one thing. This is NCLEX, okay, already. So unrelated to the sclera. So in the sclera, we have a pigmentation sometimes, pigmentation that is called jaundice. Jaundice, the other name is icteria. Jaundice, they're correcting me here. Jaundice, okay? Jaundice. Yeah, jaundice. Okay. So jaundice, icteria. So where is coming this jaundice? This is a pigmentation that is kind of yellow, greenish. Do you see people with jaundice? Jaundice. With green, with yellow colored skin? Yes or no?
Yes.
Yeah.
Yes.
Right? Okay, so we are going to see how is that happen. Okay, it's a little bit a loop here, but actually it's going to be repeated many times, and we have the time to do it. All right, so here number one, we have the red blood cells. The red blood cells, and the red blood cells, they have a span life of 120 days. 120 days. After these 120 days, the old red blood cell are going to die in the cemetery, and the cemetery is going to be the spleen. So the spleen said, okay, how old are you, red blood cell? 120. Okay, I need to kill you. So you're dead. Okay, so the red blood cells are coming, and the spleen is where it's going to basically break down the red blood cell. The red blood cells are going to open millions and millions of red blood cells at the same time. And what we have in the red blood cell, we have hemoglobin. These hemoglobin are going to be released from the red blood cells who are being broken, and these hemoglobin go to the bloodstream. In this scenario, they are going to mix hemoglobin plus water, and that is going to lead into bilirubin. This is the pigment that actually is yellow greenish. So bilirubin, then what happened, are going to be in the bloodstream. They're going to go in the bloodstream, and from the bloodstream, the bilirubin are going to be captured by an organ called the liver. The liver. The liver is like a bartender. This is his tie here, a bartender. And you ask the bartender, give me a bile. What drink do you want? Bile. So bile, bile is going to be what? It's going to be cholesterol. We talked about in the past. Cholesterol plus bile acids plus what? Water plus electrolytes plus bilirubin. Bilirubin. So all these, the bilirubin then are going to be captured by the liver. The bilirubin is captured by the liver. But if the liver is not working or the liver is failing, so the bilirubin are going to be increased in the bloodstream, into the bloodstream. So bilirubin are going to be distributed all over the tissues, the skin, the liver, everywhere. I mean, the spleen, the kidney, everything is going, nervous system are going to be distributed the bilirubin. In excess, they are going to start having pigmentation of the sclera of the eye, the sclera of the eye. So, and that is going to produce, are going to be called the jaundice. You okay with that?
You said when the liver fails, that happens?
Yes.
So what happens when babies get the jaundice?
Oh, okay. Who is this? Daniela, right?
Yeah.
Yes, okay. All right, so, but before answer that question, I want, if this is clear, please.
Yes.
Yeah.
Okay. So this bilirubin is coming from the death of the red blood cells. That's what I want you to get, okay? So when the red blood cells are going to die, 120 days, so that means 4 months is the lifespan of the red blood cell. When this all, they are going to be destroyed by whom? By the cemetery spleen, and they release the hemoglobin, and hemoglobin in combination with the water produce bilirubin. And the job of the liver, one of his job is to capture the bilirubin. If the liver is not working, bilirubin cannot be captured by the liver, so bilirubin start to get higher levels in blood. And that is going to pigment your skin and other areas of the body. Now, let me finish this before I answer your question, Ms. Daniela. Is this, that the bilirubin, NCLEX, HESI, ATI, so remember that the first place where you're going to find the bilirubin present in the skin and in your body is the scleras. Sclera is the number one place. It's the first place. So NCLEX. So don't forget that. So the first place where you find the pigmentation is going to be the sclera. Number two, you want to know where is number two? Number two is the skin. But later on, I'm going to show you some tips, some tricks later on, but not now. Okay, so now, is that clear? All right, Daniela, so you're telling me, you're giving me candy with that. So, okay, I will explain you very fast, okay? All right, so look at this. The baby fetus, when they tend to have a jaundice that is called physiological jaundice, okay? Why is that happen? That happen generally. The most common is the fetus in the uterus are going to have a different type of hemoglobin. This different type of hemoglobin is called the fetal hemoglobin. This fetal hemoglobin, when the baby is born, they need to be replaced by the adult hemoglobin. It's a different type of hemoglobin. So in this period, the fetal hemoglobin is going to start to be destroy the red blood cells who contain this hemoglobin. So it's a lot of fetal hemoglobin. This fetal hemoglobin is producing what we call the physiological jaundice. Now, when the jaundice needs to start 3 days after birth, that is normal, and that is going to last for a week. But if the jaundice starts at the very beginning after just they born, that is abnormal. that should be investigated. It could be hemolysis, could be many reasons. Okay? All right. That answer your question, Miss?
Yes, thank you.
Sure. Okay, so we are talking about the sclera. All right, the sclera. Then let's go. This is the outer layer. So you already know what is the sclera. Let's go to the middle layer. The middle layer is called the choroid membrane. This is the choroid membrane. We have three layers, remember. Retina, sclera here. This is the choroid membrane. Choroid membrane is a very vascularized layer. Vascularized. What means vascularized?
A lot of blood vessels.
A lot of blood vessels. Beautiful. That is what we mean vascularized. A lot of blood vessels. Why is it? Remember, don't lose the angle, please. Remember, we are in a sphere. This is not just a line, it's a cover 360 degrees. That is the choroid membrane. And on the top, we have the sclera. The sclera. Below the sclera, the choroid membrane. And that is going to give blood supply to whom? To the sclera and to the retina, that is the more inner layer. So that is the choroid. So you want to see the choroid? Probably you saw it, and maybe you don't know you saw it. And I will tell you how. Do you take pictures, right? In the past, they was taking a lot of flash pictures, right? Pictures with flashes, right? But still, somehow, do you see some, at night, you need to use flashes, and sometimes some of the guys or some of the girls are going to appear with the red eye, right? The red eye. So you see that? This red eye, what does it mean? The red eye is that basically the person when they're taking the picture, the light, the flash was exactly getting into the choroid membrane of that person. That red eye is a picture of your choroid membrane. The choroid membrane is red? Yes, it's totally red. Why? Because there are small vessels with a lot of blood. So that is if that was a mystery for you, well, now it's resolved. Okay, the red eye is just the picture of the choroid membrane. Okay? All right, so let's keep moving. And who is going to be a star today? No? Nikki, you're hiding. No, you're hiding? No? Okay.
Yes.
Yes. All right. The third layer is going to be the inner layer called the retina. All this yellow, that is the retina. Is the retina. Please remember 360 degrees. Your room is the eye, and all the painting around this room you will see is the retina. Is the retina. Okay. What is the retina? Retina is a nervous tissue. And where is coming from the retina? The retina is coming from the optic nerve. The optic nerve. These optic nerves are going to have millions and millions of neurons. They're going to lay, so in between, related, whatever. So millions and millions of nerve cells. And these nerve cells together are going to form what we call the optic nerve. Optic nerve. Which cranial nerve is the optic nerve, please? Optic nerve. What is the cranial nerve number?
2.
How many eyes you have?
2.
Excellent. Right? Optic nerve number 2. Okay? So when this optic nerve coming this way, they are going to get into the inner portion of the eye. And in this moment, this like a cord, like a rope, are going to expand like this, all this inside. So the retina is the continuation of the optic nerve. I want you to keep thinking about in 3D dimension, 360 degrees. So you are in the eye, you are looking inside the eye, and that is basically the retina. And the retina is going to come from the optic nerve. Okay with that? Okay?
Yeah.
Yes.
Okay, so and that is the three layers of the eye. So simple, right? So we have three layers, three chambers. Three layers, three chambers. So three layers you already know: the outer, the middle, and the inner. And we already know what is the function of the retina, as I mentioned. Retina have neuroreceptors, specifically photoreceptors, receptors who are sensitive to the light, and that is going to transmit the electrical impulses into the optic nerve that they go to which lobe for vision? Which lobe?
Occipital.
The occipital lobe. Very good. The occipital lobe. Everybody, please participate. Okay. Otherwise, I need to start asking everybody. I don't want to I mean to point to anybody. I'm not pointing anybody, but I don't want to keep asking, please. Okay. Thank you. All right. So then we have the three chambers. Three chambers. The three chambers are going to be very important. But before to go to the three chambers, we need to know the boundaries, because the chambers are having boundaries, and you need to know where are these boundaries in order to define where are these chambers. Number one, we have the cornea. This is the cornea. The cornea is the most anterior. Then we have here, this is the iris. This is the iris. The iris, remember, is 360 degrees, so please. 360 degrees. This is the iris. 360 degrees, but in this image we see only as a cut, right? Okay? So these iris are going to be muscle. That is a smooth muscle, but is what we call the intrinsic muscle. Intrinsic muscle. What means intrinsic muscle? Intrinsic muscle means inside. Inside whom? Of the eye. So this is an intrinsic muscles. This is the iris. The iris have the ability to contract or relax. So that area here we have, I'm going to go back. Here, this black area is the pupil. This pupil is just a space. It's just a space. There is no structure there. So this space is where the light is going to coming into your eye. So you already know that when you have too much light, what happened with the pupil?
It gets
Smaller, right? And
Yeah.
what happened with when you have dark? Your pupil start to get dilated. Correct? So these having names, and that's what I'm going to ask for the next exam. So we have here the mydriasis, and the meiosis. Please, I didn't say meiosis, I said meiosis, okay? Mydriasis when the pupil are dilated pupil. And the pupil here in meiosis are going to be very narrow. It's going to be constricted. Okay, we okay with that? How to remember this? First of all, you need to get familiar with the names. Mydriasis, meiosis. So write it down 10 times, say it 10 times. That is going to be more than enough. But you need to know what is the opposite of mydriasis. What is the opposite of meiosis? That is something I'm going to ask. Mydriasis and meiosis. Meiosis. So how we are going to remember? Mydriasis, once you already been familiar with the names, mydriasis take longer time. Longer, bigger. So bigger pupil. And meiosis is short name, short word. So the people are going to be more narrow. Okay with that?
Yeah.
Yes.
Okay. Why is important to know that? Why is important to know that? Do you being stopped in the highway for over speed? Nobody? No?
No.
Okay, Tom, what was your record in highway? What is your record in highway? I will tell you my record.
I think mine was like probably 100.
100?
Yeah.
Well, I promise it's true, it's very honest. 115. I was at 115. That was those times, so craziness, whatever. Okay, so and that is on Highway 5 when going south. Yeah, going 5. So that was and the police didn't stop me. Sounds God. Anyhow, so another things. And when the police stop you in the highway, what do you have maximum speed? And say me, Nikki, you're laughing because you did something, right?
No, I just thought it's funny how you didn't get caught for
You
going
get
over 100.
or you were cut over 100? Really?
What?
You were you was driving more than 100 miles per hour?
No, you.
Oh, okay. All right. So what happened is the police stop you. The police stop you and make the flashlight. And you will learn something from this, huh? So I'm not saying, I'm not talking because whatever, right? For a reason. So pay attention. So, and the police is putting the flashlight inside the car and put it in your face. He says, oh my God, this is stupid police, right? So they are actually trying to bother me or what, right? But the police is doing that in purpose. Why? Because they want to see your people. They're trained to check the people very fast. See, Karina, see, you say, oh, that's why. You say, right? Okay, that's why. Okay, that's good. All right, so now, what happened is the people is like this. When you have too much light, the police is going to see like this, narrow, immediately, right? And then come back again. So that is the normal. If your people is like this, dilated, dilated, regardless of the light or not, that means that you are driving under the influence. And they cut you immediately. Okay, so go down the car. Step down, right? All right, so, and that means cocaine and means marijuana. Okay, so that is DUI. Yeah, DUI. Sorry, I get confused with IUD, but it's DUI. Okay, DUI. Okay, DUI is going to be that is the sign that the police is going to check. That is called midriasis. Midriasis. If you got somebody on the street falling down, totally like knockout, the first thing you're going to check, besides the respiratory system, you're going to check the pupils. If the pupils are pinpoint like this, pinpoint, very tiny, without response, that patient most likely have intoxication with LSD, opioid, morphine. Okay? If you have a patient, for example, have a car accident, and the patient, you're looking the eyes, you see that one eye is normal, but the other eye is dilated. So that means the patient is bleeding from the head on the right side. So whatever is dilated here and normal on the right side here. So this is telling, it's like the body is telling, please help me. Look inside. I'm bleeding in this side of my head, just to make you remember that. Okay? So the pupils are going to be very important component. And the pupils are related to the iris. Iris is the smooth muscle that can lead into what? Into midriasis and meiosis. ¿Vio qué vida?
Yes.
Yes.
Kat, you like purses? Yes, you like purses. Okay, what happens when you see a Gucci purse in front of you? Wow, right? Your eyes are going to be very open, right? Why is where the pupils are going to be dilated, correct? Why? Because if we like something, we want to have more light to see it. We're excited. Why? Because we have adrenaline. Adrenaline is the one who make the pupil dilate. Okay, ¿de qué vida? So that is the pupil. All right. Just remember the muscles are related to the iris. The iris are a smooth muscle that are intrinsic muscles. ¿De qué vida? All right.
Yeah, yeah.
All right. A little bit about iris. Oh, Rachel is there. Okay, wait. Okay. So we have, where is my pen? Okay, we have the cornea. I need to talk about the cornea a little bit. The cornea, you need to be very careful with the cornea. The cornea is the more anterior portion of the eye, and the cornea have 5 layers. If you don't want to remember 5 layers, don't remember 5 layers. But I'm telling you, if you have the cornea is I'm going to make it like this. We have 1 layer, 2 layers, 3 layers, 4 layers, 5 layers. So these 5 layers, this is the outer layer, the outside of the eye. If you injure your eye in the first and the second layer, the cornea is going to heal without problem, no problem. But if you injure your cornea, the first, second, and the third layer already, that is going to lead into a scar. So you need to be very careful with the cornea. The cornea can be damaged in many ways. It could be, for example, a simple trauma. A simple trauma. Somebody hit your eye, it's a trauma. So you can disrupt the surface of the cornea. You need to go immediately to the ophthalmologist, and they're going to put you like a very thick dressing on the eye and close the eye for many days with antibiotics and painkillers because it's a lot of pain. So you can open the oven and the fire is coming. They can damage your cornea. So be careful with the cornea, okay? So the signs and symptoms of cornea, how you can tell is a cornea problem. Cornea, you will find that is a lot of pain in that eye. Number 1, pain, red, and a lot of tears. It's like you're crying, but it's a kind of a very, very weird crying because you're crying only in one eye. When you cry the left or the right? Right?
I don't know.
Both eyes.
Both eyes, right? You don't cry with one eye only. Right? Okay.
Oh, I thought you meant like which tear comes out first.
Oh, do you have an answer, Erica? Nikki, sorry?
I don't.
Okay. Okay. All right. That's okay. So you cry with both eyes, please. Okay. All right. Okay.
Yeah.
So now, okay. So a lot of redness, pain, red, and tears. That is very important. So recognize that. Okay. So be careful with the cornea. All right. So let's keep moving. Here we have the cornea, we have the iris, we have the pupil. Below that, please, some background. Here we have the lens. This is the lens. Okay, the lens. This lens, I'm going to start giving you some guidance here. The lens is attached to some muscles here. These muscles. Remember, the lens is around, it's like a disc. And remember, 360 degrees, so the muscles are like this, all over the lens. And what are these muscles? These are going to be called the choroid muscles, the ciliary muscles, sorry. It's called the ciliary muscle. For a second, I make a mistake. Ciliary muscles. These ciliary muscles are making stretch out, and they're going to contract and stretch out the lens, or they relax and the lens become more chubby. So the lens are going to change shape. So because of these ciliary muscles, why? Because these lens can be, when they stretch out in this direction, they're going to pull the lens in 360 degrees. What happened with the lens? The lens become very narrow, and that is to look for the distance. But when you relax, the lens are going to accommodate to the short vision, are going to relax, and the lens become more chubby. So I'm going to give you an example. You want proof of that? I'm going to give you a proof of that. The proof of that is this. Homework. You're going to take a reading paper, and put it on the distance. And then all of a sudden, you're going to do this. You're going to take the book in front of you and you're going to do exactly like this. And try to read. You will not be able to read immediately. So what you're going to do is to have the accommodation. Who is accommodating? Is the lens through the ciliary muscles. You okay with that? That is called the accommodation. 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 Okay? Accommodation for what? Basically, accommodation is to accommodation is the terminal name for that, where the lens is going to have the thickening according to the distance that you're trying to look at. The accommodation is actually to focus your eye. So focus to the distance, focus to the short distance. Okay, all right. So that is the lens. Oh, in addition to that, lenses are going to have some opacities, some cloudy areas with the time. That is called the cataract. Cataract are going to be the most common surgery in United States. Okay, cataracts. So what they're doing is to take it out, remove it, and put a new one. Okay? We okay with that?
Yes.
Yes.
Okay.
Yeah.
All right. So next, we have here the vitreous body. Now we are ready to talk about the chambers. Okay? The chambers are going to be 3 chambers. One chamber is going to be the anterior chamber. So if we have anterior, you have posterior, correct? Right? And the other one is the vitreous body. I'm going to make emphasis in this because many students make mistakes. Okay, so it's not uncommon mistakes. So please be careful with this. Where is the anterior chamber? The anterior chamber go from the cornea to the iris. So now we are talking, that's what I was taking, the boundaries. The cornea, I'm going to put here, from the cornea to the iris. So that is the anterior chamber. Anterior chamber. Anterior chamber. Where is now the posterior chamber? The posterior chamber are going to go from the iris here, from the iris to the lens, including the lens, the whole lens. Can you see this? That is the posterior chamber. Posterior chamber, posterior chamber, posterior chamber, posterior chamber, posterior chamber, posterior chamber, posterior chamber. Right? So they go from the iris to the lens, including the whole lens, the posterior portion of the lens. That is the posterior chamber. You okay with that?
Yeah.
Yes.
Okay. Now, here, posterior, listen what I said, posterior to the posterior chamber is called the vitreous body. This vitreous body, because it's more behind or more on the back, that doesn't mean that is the posterior chamber. No, this is called vitreous humor or vitreous body, either way. Okay? So this vitreous body is a fluid that is gel. It's a gel. A gel. It's a gel, like a gel. So this gel, what it's doing is to help. And remember that question for the exam, help as well for the shape of the eye shape. So who else is helping for the eye shape is the sclera, correct? Sclera and the vitreous body or vitreous humor. I call vitreous body better, but you need vitreous. Vitreous is the word, the key word. So that is a gel. That is going to be a gel. You okay with that?
Yes.
Yes.
Okay. So now,
Yes.
and the vitreous body is going to go from the posterior portion of the eye down to the lens. So all this is the vitreous body. All this is the vitreous body. Vitreous body. Okay?
Yes.
Okay.
Yes.
Yeah.
All right, next. Here, oh, by the way, do you know somebody who has glaucoma? You heard
Yes.
somebody having glaucoma?
Yeah, I
Yes.
do.
Yeah. And tell me, what is the main complication of glaucoma? Blindness. You become blind with glaucoma if you don't take care of your glaucoma. Glaucoma is a chronic situation. When you are being diagnosed with glaucoma, you are actually that is for the rest of your life. Okay. All right. So always there are some mistakes or misdiagnosis. Well, that is the function of the ophthalmologist. Okay. So today we are going to learn what happened with glaucoma. Today you are going to learn how the glaucoma is going to happen. Okay. So for this, going to make a small break. Yes, I know, I know. A small break, and we are going to come back at 6:30. We okay with that? Okay.
Yeah.
Okay.
And
Thank
take a
you.
coffee or something, tea. Don't take chamomile. Chamomile, going to sleep. Okay. Thank you so much. See you then. Start to be chilly here. I prefer to go residential sometimes because I'm moving. Sitting in a chair, it makes me feel cold all the time. Teresa, do you hear a sound on my side, like a TV or something?
A little bit. It's not too bad though. It's in the background.
No, but it's okay. Is disturbing or no?
No, not for me.
No?
When you talk, I can hear you.
All right. All right. Thank you. Thank you. All right. So 6:30. So let's get a start, please. All right. So now we have the eye here, and we already know what is the anterior chamber, posterior chamber, and the vitreous body or vitreous humor. Okay. All right. So let me change my glasses. Okay. So here we have one structure that we are going to start talking about glaucoma. Glaucoma is going to be an example to try to, in additional, incorporate all these anatomy scenes that are happening and to make sense about all that. All right, so here we have in the posterior chamber, in the posterior chamber that is in between the iris and the lens, we have here a structure. If you see here all this structure, that is called the ciliary body. First of all, where is the ciliary body? In the posterior chamber. Okay? So that is the ciliary body. What is doing the ciliary body? The ciliary body have three components. Have the ciliary vessels, have the ciliary muscles. Remember, 360 degrees all around the surrounding the lens. And the other one is the ciliary body, the ciliary glands. The ciliary glands. That is important. The ciliary glands are going to produce. The ciliary glands produce the aqueous humor. The aqueous humor. Okay, this is very important. So these are 360 degrees, all right? So all around the lens, don't lose the perspective. So they are going to produce fluid. This fluid, the aqueous humor is going to flow all the posterior chamber. All the posterior chamber are going to be with this fluid. This fluid is going to be in the posterior chamber. After this, what happened with this fluid? This fluid are going to start getting flowing into the anterior chamber. So they're going to get into the anterior chamber, and they're going to flow that again. So the anterior chamber and the posterior chamber are going to be surrounded or contained the aqueous humor. You okay with that?
Yes.
Yeah.
And saying aqueous, you said?
Aqueous humor, yes. See that? Is that clear or no, please?
Yes,
Yeah.
it's clear.
Yes.
Yes.
All right, so who produced that? The ciliary glands. And where are the ciliary glands? Coming from the ciliary body.
Body.
Where is the ciliary body? In the posterior chamber.
Posterior chamber.
Okay, excellent. Now, the aqueous humor is actually going to give, they are going to do something else. Once the aqueous humor is formed, produced, they're going to be producing aqueous humor 24/7. And the fluid that is coming this way, passing through the pupil into the anterior chamber, they need to be drained out. They need to be drained. The drainage is going to be here in the anterior chamber. The drainage. This drainage is called the meshwork, or most commonly in exams are calling the Schlem's canal. Schlem's canal. Schlem's. I'm going to write it down here. H. I think Schlem's canal. All right. Schellmmn canal. So that is where it's going to drain the aqueous humor outside of the eye. All right. Now we are ready to talk about glaucoma. We have all the components. Okay. So this fluid that we have here in the anterior posterior chamber, that is the aqueous humor, are going to create a pressure in the eye, pressure inside the eye. If you go to the ophthalmologist or the optometrist, they are going to measure the eye pressure. Do you know that? Do you check that?
Yes. And
Right.
I hate it when they do it.
Yeah, because they're like blowing a small air like this, right? And what happened is that if there is a lot of tense on the eye, the rebound of the air is going to go faster, stronger, faster, as strong as it was released. So the more the blow coming back, they're going to measure the pressure of the eye. Well, that is a way. Now, this pressure of the eye are going to be called the intraocular pressure. Intraocular pressure. That is a problem for the person who have glaucoma. 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 Okay? They're going to end into blindness in the long run. Intraocular pressure, we call the IOP. Intraocular pressure. And the intraocular pressure is going to normally be between 8 to 22 millimeters of mercury. Okay? You okay with that? Question.
Yes.
Yes.
All right. So
Yeah.
who is giving which element is going to produce the intraocular pressure? Is the pressure of the aqueous humor. You okay with that?
Yes.
Yeah.
Okay. When you have increased pressure of the aqueous humor, what is happening is that they're going to make increased pressure. They're going to increase pressure here in the anterior chamber and the posterior chamber, anterior chamber and the posterior chamber. This increased pressure of the anterior posterior chamber are going to push back the vitreous body. This is a gel, and this pushing back of because we have an increase of the IOP, they're going to squeeze and push the entry of the optic nerve. So basically, they're strangulating the optic nerve, the entry of the optic nerve into the eye. And just remember, we have thousands of millions of nerve cells here. So this strangulation or mechanical pressure caused by the increase of the intraocular pressure are going to be pressing the optic nerve at the entry of the optic nerve. And what happened? One by one, the nerve cells are going to start dying, dying, and dying, and dying. And that is going to produce a progression of the loss of vision, and that is irreversible. Okay, so what we need to do is to do what? To decrease the intraocular pressure. You okay with that?
Yes.
What
Yes.
makes the pressure go higher?
Sorry?
What makes the pressure go higher in the,
Who said that? Who said that? Daniela?
yeah,
Yes, Daniela. That is my next step. I'm going to go on that right now. Excellent. Okay? All right. So now what is happening here? And that you're going to see a med search in pharmacology. And I will tell you there the next level will be which medications are going to decrease the intraocular pressure. That is NCLEX, but sure they're coming. So I'm going to explain you now. Look at that. Here we have the exit of the aqueous humor. It's called the Schlemm's canal, right? That is for drainage. They're going to drainage, okay? So that is how they're coming out. They're coming out, no out in the, they're going out to the lymphatic system. Okay, so but the thing is that coming out. And the other key is the ciliary gland. Ciliary gland. Ciliary gland. So what are going to be the problems? The ciliary gland is going to produce the aqueous humor. So what could be the problems for increase of intraocular pressure? The increase of intraocular pressure will be basically by two causes. Number one, and you think about that right now and tell me if it makes sense. Increase the intraocular pressure. Why? Because there is excessive production of aqueous humor. You okay with that?
yes.
Yes.
And the other cause, that is going to lead into an increase of intraocular pressure. And the other option is there is a decrease on the drainage. If you have decrease of the drainage, the fluid starts to accumulate, increasing the intraocular pressure. Okay with that?
Yes.
Okay, so that is what happened in glaucoma. In glaucoma, they're going to have two options: or increase the drainage of the aqueous humor, or decrease the production of the aqueous humor. Okay, you will see, for example, I will tell you, alpha 1, alpha 2 receptors are going to decrease the production. The beta blockers decrease the production. The cholinergics increase the drainage. The diuretics, osmotic, carbon dioxide, whatever, are going to decrease the production. And prostaglandins are going to increase the drainage. So that is the level you're going to get in pharmacology. That is the level that you're going to get in MedSearch. So at this moment, I just go to the simple thing. So if you remember that, I'm going to give you a mnemonic how to remember the rest, but this is not your time. But that is the principles of glaucoma. You okay with that?
Yeah.
Yes.
Yes.
So I will talk to you about signs and symptoms, but this is not the case right now. But if you want to talk about signs and symptoms, we can talk about that if you want. Very brief, of course. All right. So so we got that. Everything is okay?
Yes.
Yes.
Okay. All right. So now this confusing chart, I start to get more sense. All right, so let's start. The eye is going to have actually filled by fluid. It's going to be two fluids. One is the aqueous humor, and the other one is the gel, that is the vitreous body. The cornea is the more anterior portion of the eye. It's a structured anterior portion of the eye. Oh, one more thing I want to tell you before I forget. How many? Do you know somebody using contact lenses?
Yes.
Yes.
Okay, contact lenses. Okay. So these contact lenses. So the new ones, right? The new users. Let's put it that way. So you put the contact lenses, and they said you need to. There are contact lenses that can be the whole day, or 3 days, or every time, every 4 hours, need to change it, etc. So some of them, or probably some of you actually fall asleep with the contact lenses. Do you fall asleep with the contact lenses? Okay. And what happened when you open your eyes? You say, "Oh my God, I
Right.
sleep with the contact lenses." And the contact lenses, you start to look in your pillow, in your whatever around you, and you didn't find it, right? I'll say, "Oh my God, so where is the contact lenses?" And then suddenly, boom, "Oh my God, it's still in my eye. And I don't see the contact lenses in my eye. So where is it? Where is it? Oh, get posterior to my eye. So it's going to go now to my brain." No, but it's not going to go to your brain, the contact lenses. Why? Because for a reason. Erika, you okay? You put your expression is like telling me, "Oh my God." No? Okay. You okay? Erika? Erika? His name is Erika?
Who's Erica?
Oh, Nikki. My God, sorry.
Yeah, yeah, I'm fine.
Okay. All right, so let's get started drawing this. So what the thing is this, look at that. So here we have the eye. This is make the iris, and this is the pupil. Okay, this is the pupil. Okay, so now here we have your eyelid. Some people have like this, right? Very natural. And like this, the eyelid, okay? Okay? All right, very fashionable now, I guess. Well, it's not fashionable anymore. But anyhow, all right. So what happened here? So here we have, this is the eyelid, the eye. And what happened is that we have a membrane. This membrane that is covering exactly over the eye. It's not part of the eye, it's a cover of the eye. And this membrane that goes surrounding all the eye until a moment they're going to reflect back. And they're going to end in the eyelid again. You got it? So now, if you have a contact lens here, when you close your eyes and the contact lens disappear, the contact lens sometimes are here. And you don't see it in front of your eye. So what happened? The contact lenses are not going to go to your brain. They're going to stop because of this membrane. This membrane is going to stop here. So what you need to do is just close your eyes, some eye drops, lubricant, and then rest a little bit, and the contact lenses start to appear bit slowly. This membrane is called the conjunctiva. The conjunctiva. This conjunctiva is basically when it's inflamed, it's called the conjunctivitis. And that's what we call the pink eye. Pink eye can lead in just simple inflammation, or they can go a viral infection or bacterial infection. Okay, so you can tell this is an infection when you have a crust in the mornings around the eyes, accumulating during the night. So this is the conjunctiva. So don't get alarmed if the contact lenses doesn't appear into your eye if you went to go to sleep. Okay, you okay with that?
Yes. Yes.
Yes.
Now,
Yeah.
Homework. I want you to pull down your eyelid with your finger here, and pull it down. And the space that you see under the eye, that is called the subconjunctival sac. That is where you're going to put the eye drops. And we are going to talk that in a few moments. Okay? Drops are here. Boom, boom. Okay, you put it here, you close your eyes, and the drops are going to basically just wash all the eye. Okay? You okay with that? Any questions so far?
No.
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 All right. So we have the aqueous humor. We already know who produced the aqueous humor. For the second time, we are going to repeat, or the third time, is is going to be who?
Aqueous.
Posterior.
The what? The what? The ciliary
The
body.
ciliary glands.
Ciliary glands. Yeah, ciliary glands are going to be part of the ciliary body. You okay with that? All right. So we're talking about the pupil. Pupil. How pupil? Okay, pupil. All right. So that is not an anatomical structure. It's just the opening that is formed by the iris. All right, so here we are going to start having some views here. This is a long view. Here we have the cornea. You see here the cornea. This is the cornea here. Then we have here the lens. This is the lens. This is the iris. This is the anterior chamber. All this is the posterior chamber. And what we have here, the ciliary process is called ciliary body or ciliary process. Is the same. Okay, so this ciliary process or ciliary body contain three structures again: the ciliary vessels, muscles, and glands. They're going to produce the aqueous humor. They go from the posterior chamber to the anterior chamber. Okay,
Yes.
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 Yeah.
now we have a transverse cut looking the eye from above. So this is anterior, this is the cornea, this is the sclera, this is the lens, here's the lens, there's the lens, anterior chamber. All this is the posterior chamber. And what we have in the posterior chamber? The ciliary body. The ciliary body are going to have, can you see these lines here? That are the
Yes.
ciliary muscles.
Yes.
And the ciliary muscles are going to be connected to the lens. Then we have the ciliary glands, and the ciliary glands are going to drain the aqueous humor. They go to the posterior chamber, and they go here to this area. That is called, this angle is between the cornea and the iris, is called the iridocorneal angle. And that is between the cornea and the iris. This angle is where is going to be located the Schlem's canal. The Schlem's canal. So I forgot. Okay. My God. Schlem, that is the correct thing. Okay, Schlem's canal. So this is the meshwork that is going to basically be draining the aqueous humor outside into the lymphatic system. Okay? All right, so let's keep moving. Here we have a more simple graphic or cartoon here. We have here the lens. All this is the posterior chamber. Here we have the anterior chamber here between the cornea and the iris. And then we have here the ciliary body. This is the ciliary body. Ciliary body can you see these lines here? These lines are the ciliary muscles around all 360 degrees of the lens. And then they're going to produce what? The aqueous humor. The aqueous humor go from the posterior chamber to the anterior chamber, going to the Schlem's canal. That is where it's going to drain. Okay? All right, so now, tell me, when was the last time you cried? When you cry, you ask for tissue?
No.
No? No, yes. Well, you cry without tissue, no. Okay? So,
Why?
Sorry? Okay. So, when you cry, you need to blow your nose, right? So,
Yes.
why? Why you need to blow your nose? You're crying from your eyes. How come it's getting into your nose? Why? Because the tears can go into your nose. I will explain you now. Look at this. Here we have the eye, and one thing I want you to remember is the caruncula. This is the caruncula. This is the caruncula. This caruncula or caruncle, it's pronounced caruncle, caruncle. So everybody can see your caruncle, right? This caruncle, actually, everybody thinks that, and wrongly, that this is where is originated the tears when you're crying, and it's not. This is not the This is very important. I'm talking about NCLEX right now, so please pay attention, okay? Caruncle are going to contain two openings here. Two openings. When the tears are coming, when you are crying, tears are coming, tears are coming. The tears are going to come into this area of the caruncle. They have two openings, and look at that. They are going to drain into what we call the lacrimal sac. They are going to drain into the lacrimal sac. These lacrimal sac are going to drain into the nasopharynx, in the nose. So that's why the tears are going to make you blow your nose, because they are going to get from the drainage at the level of the caruncle. That is very important. I didn't finish. So now, next page is, where do you think is coming the tears? The tears is coming from this gland. This is the gland of tears. And this is the lacrimal gland. Lacrimal gland. Question for the exam. They are going to drain into the eye. So where is located? In the upper outer quadrant of your eye. Upper, outer quadrant of your eye. So that is where you have the lacrimal gland. So that is where it's coming the tears. Okay with that?
Yes.
Yes.
Tears are coming, crying,
Yes.
crying. And all these fluid are going to get into the caruncle, the here openings in the caruncle that are going to end into the lacrimal sac and then into the nose. Okay with that?
Yes.
Yes.
So next, this is what all the explanation is just to tell you about NCLEX. Now, what happens when you have eye drops? When you have eye drops, for different reasons, could be antibiotic, could be an anti-inflammatory, could be antihistaminic for allergies, right? And you're going to put here, you're going to pull down your lower lid, and they're going to go and see the subconjunctival sac, correct?
Yes.
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 Now you're going to put two drops. Drops is the capacity of the subconjunctival sac. Two drops. Two drops are the capacity of the subconjunctival sac. So if you put more, you're going to just waste. It's a waste. So what happened? These drops are going to be here. You close your eyes and it's going to lubricate all over your eye. But these fluid are going to drain what? They're going to drain through the caruncle, where the openings of to the lacrimal sac, and they go to the nose. So if you want to keep the medication stay longer into your eye, what you're going to do, that is NCLEX, you're going to put your finger here. This is your finger, and press here. Pressing here, you're going to block the exit of the fluid. And you keep it for 1 minute, it's enough, and then you release, and then the fluids are going to start draining. So what is the purpose of this? Is to make longer contact with the medication to the eye. Okay with that?
Yes.
Yes.
You can
Yeah.
repeat the process every 5 minutes, 2 times. Okay? All right, so we okay with that? Excellent. Oh, very
Yes.
nice. Tear gland. Okay, we have the lacrimal sac. This is the lacrimal sac. And they go into your nose, and this is your tissue, facial tissue, whatever paper you want. Okay? All right. So that
Okay,
is,
G.
yes, go ahead.
So when, like, if someone has a sty, is it because their lacrimal gland is like congested, or is there
Okay.
like a blockage in the gland?
Okay. Who said that? Kathy, right? Kathy.
Yeah.
Okay. Kat, homework, okay? Homework. So everybody's going to look at the mirror, and you see in between the eyelashes. In between the eyelashes. You see some openings there? You see some openings, right? Those openings are glands that are going to secrete an oily fluid. So you see, in the morning you have some oily fluid, oily secretion around your eyes. Do you notice that? Right? So this oily is to keep moisture the area because you don't want to make it dry. Now, what happened? This Okay, I'm going to write it down for you guys. What is this? Oh my God.
That was funny.
Okay, I kicked myself out. Okay, sorry. Okay, sorry. So it's recording, yes. Okay. So the gland is called the meibomium. Okay, let me find meibonium, meibonium, meibonium gland, meibonium within gland. This meibonium gland are located here in between the
Wait,
eyelashes.
Dr. G, are you sharing your screen?
You can't
Oh,
see.
Lab presentation.
Thank you.
okay. All right, can you see now?
Yes.
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 This the meibomian gland are located here in between the eyelashes. In between the eyelashes. Do you notice that?
Yeah.
Okay. And these actually the upper and the lower lid. So these glands are going to produce an oily secretion that are going to keep moisture the eye. So in order to prevent cracks, okay, because it can be dry and cracky. So what happened here? These meibomian glands that produce that fluid, that oily fluid, when you use mascara, how you call that? Mascara,
Error.
Era.
mascara,
Mascara.
like
Yes.
this, mascara here,
MAS.
M-A-S, C,
C.
okay,
E.
C, okay. So, okay, mascara. Some people put a lot, right? And when they put a lot, they are going to block the exit of the one of these glands. When they block the exit of these glands, the secretion starts to accumulate, get infected, and get what we call the sty.
Mhm.
Okay?
Yeah. Thank you.
Sure. All right, so talking about the cornea, just remember we have 1, 2, 3, 4, 5 layers. So if you destroy up to the second layer, it's going to heal without any problem. If you destroy down to the third layer, it's going to be a scar. So be careful with that, okay? All right, so let's keep moving. The iris. The iris is basically the entry is like a diaphragm that is going to be constricted or dilated, right? Dilated means mydriasis, question for the exam, and meiosis when it's constricted, very tight, okay? Just remember, those are part of the intrinsic muscles, why is muscles are inside the eye, okay? The crystalline lens, we have here, another here, we have the ciliary body here, the ciliary muscles. Ciliary body produce the aqueous humor, and this is the Schlemm's canal. So the crystalline is, I mentioned already, they can they can be cloudy with the time. And this cloudy means cataracts. These cataracts are going to be the most common surgery in the United States. I mentioned that already, right? So, and this is going to be replaced by a new lens, okay, crystalline lens. Okay, so the vitreous body is a gel that is going to help to maintain the spherical shape of the eyeball. You okay with that? And the retina is the inner layer of the eye. We know that is a continuation of the cranial nerve number 2. Okay?
Yes.
Okay. So now let's go to the retina. For that, I'm going to show you a picture here. All right, so look at this. In this image, you will see here the inner lining of the eye is going to be the retina. But in the retina, look at this. It's coming this way. Boom, 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 all the way. 360 degrees, please. And then, boom, down. It's going to be like an indentation and then go up again. So this indentation are going to make it here. So it's going to be something like this. Okay, this indentation from here to here, all these area are going to be called the macula. The macula. The macula. Okay? And the most inner portion here, the most deepest portion of the macula is called the fovea. Fovea. So why is important to know that? To know that, we need to remember that the retina are going to have two type of photoreceptors. Photoreceptors. These photoreceptors are going to be the cones and the rods. Cone and rods. The cones, C-O-N-E-S, is going to be for sharp vision. Sharp, bright vision. And for colors. Colors. How do you know you have a sharp vision? You can tell you have a sharp vision when you see any object a certain distance from you and try to see the borders, the lines, the borders of the objects. The borders of the objects should be very neat, very defined. You can differentiate. People who cannot have a sharp vision, they have like a gray area between the borders of objects. So that is the sharpness. And who is doing that? The cones. Cones. Sharpness of the vision, brightness. So when you have too much bright light, the cones are going to be used in that situation. And colors. Colors. Question for the exam. How to remember? You can tell me now how to remember, right? Colors, cones, colors, colors. Okay, you agree with that?
Yeah.
Now, the rods are going to be for night vision. Night vision. How to remember the rods are for night vision? Rods. You have a person here that is walking with some stick. This stick or rod are going to be the rods of the photoreceptors. You okay with that?
Yes.
Yeah.
Yes.
Okay.
Can't.
All right. All right, so this is the rods, night vision. Now, I want just to explain you a few things here. The rods are for night vision. Night vision. Question for the exam. We have the vitamin A. The vitamin A is called the retinoic or retinol or retinoic acid. Retinoic acid, isotretinoin. I just want you to know retinol, okay? We have the carotene as well. Carotene is not vitamin A. Carotene is a precursor of the vitamin A. So where is the carotene? Somebody can tell me where's the carotene?
Carrots.
Excellent, very good. Good. Okay, carotene, carrots. Okay, carrots. So these carrots, the carotene, that is a precursor of vitamin A or retinol or retinoic acid, etc. Retinol is the most common. I'm going to ask that. Retinol are going to basically maintain and repair the cones. The cones. They are not going to do anything with the cones. You okay with that?
So they repair
Cones
both.
and rods, because you're pointing at rods.
Sorry?
Said repair retinol
You said-
repair.
Repair
You said
only
rods.
the rods,
Okay.
not the
I just said
cones.
Repair what?
Who's asking? Your microphone is no good, or what happened?
I can't hear you. You said repair because we were talking at the same time.
Who said that?
Rochelle.
Rochelle. Okay, Rochelle. The vitamin A only works on the rods, period.
Mm-hmm.
Okay?
Mm-hmm.
And the only work on the rods, not on the cones.
Mm-hmm.
I want everybody's here. Yeah. Not on the cones. Is that okay? So when you
Yeah.
have
Retinol. You said something about retinol repairs.
the cones,
Okay.
what is retinol? Rachel, what is retinol?
Of
Retinol is the vitamin A.
yeah.
So the vitamin A is the same to say retinol or retinoic acid.
Okay.
Okay? We got it?
Yes.
Okay. All right. So tell me, Rachel, you yourself, what happens if you suffer from deficiency of retinoic acid or retinol?
You need to take vitamin A.
Yeah, no, but what are the consequences of, yeah, you need to take vitamin A, yeah, but sure. But what is the consequence of that? See, what is the function of the rods? What is the function of the rods? Everybody?
Night
Night vision.
Night vision.
night vision.
So if you don't have
You
vitamin
won't,
A to maintain the rods, what is going to happen?
you won't be able to see well at night.
Exactly. That is called night blindness. The deficit of vitamin A causes night blindness. You okay with that?
Yes.
Yes.
Yeah.
When you're using Rina, because you're in the beach, I'm going to tell you, when you go to the beach, you go Cancun, whatever, Puerto Vallarta, Isla Mujeres, whatever you like, Virgin Island, whatever, when you're going to take a tan, eat a lot of carrots. 1 day, 2 days before. When you have these carrots, they give you, the tan is going to be very crispy and it's going to last longer. I always do that. When I go to the beach, I try to be like a charcoal. I like to be burned to the maximum. And actually the tan is going to be, well, some people, it was funny, African American, they was passing and say, "Hey bro, how are you, brother?" They was because I was very, very dark. And I love it. I like it. Especially with the tan of the carrots, you will be like very, very special. Yes, believe me, do that. Okay? All right.
So, Doc, thank you so much for saying about the vitamin A. So now I know what to take because I can't drive during the night.
Yeah, yeah, yes, that is true. So, but Rina, I will tell you something. You see these people saying, you know what, I don't want to drive at night. Why? Because everything looks so different. You hear that? You need to suspect there that vitamin A. Okay, so you go there and say, okay, take your carrot, eat your carrot, eat carrots. Okay? All right, so we okay with that? All right. So now, here we are going to continue. We didn't finish that part. Here we already know about the rods and the cones. And actually here I'm going to redraw here about the macula. I'm going to redraw the macula here. So this is the macula. From here to here, all this is the macula. All this is the macula. Macula, macula, macula. On the bottom, all this is macula. I'm going to put macula here. But in the middle, in the center of the macula, here we have the more deeper area. It's called the fovea. So don't get confused, please. Fovea is part of the macula. Macula is the overall, but in the bottom, at the end, at the bottom of the macula, we have the fovea. And what is the macula doing? The macula is where we have the highest concentration of rods and cones. Okay? And what is the difference with the fovea? The fovea is where we have even much higher concentration of cones. ¿Me okay with that?
Yes.
Yes.
Excellent. So that is about the macular degeneration you heard about in the past. Sometimes we don't know what is the cause of the macular degeneration. You know somebody with macular degeneration?
No.
Okay. All right, so the macular degeneration, but you heard about that?
No.
No? Okay. All right.
Yes.
Macular,
Yeah, I've heard of it.
okay. Macular degeneration. That's fine. I mean, you are here to learn, right? So not everybody know what is macular degeneration. That's fine. And so what happened here is basically after traumas. We don't know what is the cause. It could be spontaneous after a certain age, but most commonly associated with trauma. So you have this whiplash in the car accident. So what happened? The choroid membrane are going to start bleeding because there's a tear on the retina because of this whiplash of the head. And these are going to start basically bleeding and bleeding and bleeding. And the bleeding is going to make detach the retina, detachment of the retina. The detachment of the retina can affect the macula, and you are losing all these, the bright, sharp vision. You okay with that?
Yes.
Yes.
Yeah.
Excellent. Signs and symptoms is one of my favorites, but definitely it's not the time to you to talk about that. All right, so I'm doing just the structural anatomy of the eye. Okay? All right, perfect. So now here we have the choroid membrane. The choroid membrane is a vascularized layer behind the retina. So it's in between the retina and the sclera, correct? All right. So that's why on the photos, pictures, we get red eye. So we already explained that. Conjunctiva. Conjunctiva is the membrane that is covering anteriorly the eye. So it's reflect back. So actually dust and all that, they cannot go behind your eye or to the brain, right? So the conjunctiva. Sclera, the outermost layer of the eye, is the white, is keeping maintaining the shape of the eye. The macula is where we have reached on cones. And the fovea, even more cones. Here we have cones and rods, yes, but concentration of cones as well. So cones are going to be like boom, boom, boom everywhere, but the cones here are going to be much more concentrated. Much more concentrated. We okay with that? Yes.
Yes.
Is there anything that repairs the cones?
It's a good question. The answer is no.
Okay. And then
Answer.
if you're colorblind, does that mean that you have like a lower number of cones or?
No, this not. Oh, that's a very good question. So it's not really the number of cones who are being affected; it's the quality of the cones. So there is a genetic disorder where the receptor cannot analyze the wavelengths of the green and the reds. That is, otherwise they will be resolve the problem. We cannot resolve the problem with that. So there's some glasses, right? So that you can filter and restructure so you can see the colors of the objects. I just saw like 5 years ago or 6 years ago was coming one product about that. But yeah, when you lose the cones, it's not possible to recover them. If the cones are being having problems, we cannot modify that. Okay?
Yeah.
Okay. So then we have the intrinsic muscles. Let's put it together. Intrinsic muscle. Question for the exam. Open eyes, open ears. Open eye, open ears. So we have the muscle of the iris that is inside the eye and the ciliary muscles that are surrounding the lens. Okay? The extrinsic muscles. And with this, we finish this part. The extrinsic muscles, extrinsic means outside. Okay? So if you see here in this image, you have lateral rectus, superior rectus, superior oblique, inferior rectus. Do we need to remember those names? The answer is no. I don't want you to remember those names. So there is muscles that are attached outside of the eye that are called the extrinsic muscles. These extrinsic muscles, what I want you to remember is there is three cranial nerves. So again, eye, three letters, three cranial nerves, three cranial nerves, three cranial nerves. Three cranial nerves are going to be what? Are going to be cranial nerve number 3, 4, and 6. The motor ocular nerve or ocular motor nerve, the trochlea, and the abducens. So I don't want you to remember yet because I mentioned that before, but we are going to ask that in anatomy physiology. At this moment, what I want you to remember is 3, 4, 6, 3, 4, 6, 3, 4, 6, 3, 4, 6, 3, 4, 6, 3, 4, 6. Okay? Those are the nerves that are going to control the movement of the eyes. Okay?
Yeah.
Yes.
Yeah.
All right, so how many letters we have in the eye? 3 letters. How many chambers?
3.
3.
How many layers?
3.
3. How many cranial nerves are going to be used for eye movement?
3.
3.
3.
3.
3. How many components have the ciliary body?
3.
3.
3. Can you find another 3? No. Okay. All right. So that is about the eye. You like the eye?
Yeah.
Okay. All right. So I think you deserve your lunch break. I'm going to see you at 7:51. We have 1 hour to do the whole. So you want to, if you're married or you want to get married and you want to know how many of you are going to have green eyes or blue eyes or brown eyes or, or black hair, blonde, brunette, I don't know, red hair, whatever you want. So we are going to learn that today. Okay? All right. Thank you so much. I will see you there. Bye-bye.
Thank you.
Thank
Thank
you.
you.
Yeah.
Sure.
Thank you.
Okay, all right, so let's get started. All right, so are you ready? Rachel, where are you?
Yes.
Yes.
I see your hand only. All right, miss. All right, let's get started. So we complete about the eyes, and let's see, this is a little bit kind of, you need to be very focused on what we are going to talk here, because we are going to use previous lectures about the DNA, and I'm trying to make actually a summary, and that's what it was taking a little bit time, because I should be start from what we have. So I'm going to make a small draw here. Okay, so let's talk about the DNA. This is one double helix. Let me see if I cannot get dizzy. Okay, I get dizzy now. Okay, all right. So this is the DNA. So we have a double helix DNA. You know, here we have the bases that are going to basically be the A, T, C, G, right? That are going to be located in the center here of the DNA. So these are called the bases. This is what having the codification to create proteins. Proteins means enzymes, means hormones, means receptors, all proteins that you have in your body. You have albumin, the codification to produce albumin are in this DNA. Okay? So just remember that it's like a spiral stairs. Okay, so these are going to be what we call the bases, are going to be the bases, and the bases are part of what we call the nucleotides. Nucleotides. If you remember your class of DNA, the bases are going to be the A, T, C, G, and the complementary, so A, T, and C, G, correct? And nucleotide is basically the bases plus the phosphorus and the piece of sugar. So, for example, a nucleotide is going to be this portion. That is one nucleotide that include the rail, the bars of the stairs, and they are going to be, that is a nucleotide. Okay, so now that we know that, we are going to determine what are genes. Genes are going to be pieces of the DNA. For example, I'm going to take this piece. That is called a gene. We're going to have another, could be a smaller piece, could be another gene. Or you can have a bigger area, that is going to be a gene. For example, a gene is the recipe to cook something, right? Protein. And the recipes can be very short, very simple, or recipes can be very elaborate. So that's why the amount of nucleotides that are being composed, a gene is variable between gene to gene. You okay with that?
Yes.
Okay.
Yes.
So how many genes we have? We have 24K, so 24,000 genes, 24,000 genes. Now, when you are going, this is in the cell who are not in the cell division yet. When you have in the cell division, they are going to cut, for example, up to here. So we have genes here, another gene here, another gene, 24,000 genes. So in this actually cut, all these are going to be recoiled and form a chromosome. A chromosome is drawn like this, but the chromosome literally is like this. It's a recoil of DNA. And all these are recoiled based on this area. Okay, so that is one chromosome. The chromosomes for these are going to have pieces that are going to form genes. Genes. So many genes for each chromosome. You okay with that? I try to
Yeah.
make it more simple.
Yes.
All right?
Yes.
All right, excellent. All right, so now, what is genetics? Genetics is the study of the genes. Genetics, study of the genes. And that are going to produce some physical and chemical characteristics, okay? The physical, physical will be the phenotype. And the chemical will be the genotype. Let's make a cake, the same example I gave you the last time, and the cake ingredients are going to be the genotype, are the chemicals, are the substances. So when the cake is ready and finished, you see a nice, beautiful cake that is overall is called the phenotype. The phenotype. So each genotype are going when you see the phenotype, that is, for example, how big is your nose, how big is your ear, how tall you are, or how is the color of your eye, skin, hair, whatever, right? So those are phenotypes. And each phenotype is like the cake. You see what is outside the appearance, but you don't see the ingredients. The ingredients to produce that structure is going to be called the genotype. Now, genotype plus phenotype is called a trait. A trait, what is a trait? When you're talking about trait, you're talking about the phenotype and the genotype. That is what imply to talk about a trait. Okay? All right. So for this, you need to remember additionally that we have the zygote that is coming from the N chromosomes of the ovum plus the N chromosomes of the spermatozoid. So we are going to have in the mother 1 chromosome, 2, 3 chromosomes, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 21, 22, 23. So we have 23 chromosomes that are coming from the ovum. And another 23 chromosomes are coming from the father. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. As a pairs, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, and the 23. Okay. So now, if you have 23 plus 23, is going to be 46 chromosomes. Now, when you have this in your body, it's happening during the zygote process. So the fertilization, fecundation, or conception, these actually are going to interact. Who are going to interact with whom? Chromosome 1 with chromosome 1. So what is the difference between chromosomes? Chromosomes are going to have categorized and classified like this. 1 chromosomes are going to classify with long arms, and that is, for example, chromosome 1. There is other chromosomes that are going to be like this, like this, like this, and like this, like a curved arms. That is going to be chromosome 3, for example. But this is from the father and from the mother. So these chromosomes that they have the same characteristics, other chromosomes can be like this, very short, intermediate short, like this. So that is another pair. So these have the same genes to have the color of your hair. For example, these 2 chromosomes are going to have a locus here, the location of a gene for color of the hair. This is the father, and the other chromosome is the mother, that is going to have another locus. They have the characteristic of the hair. I'm not talking about color yet. So it's like you have a department of human resources and department of human resources. 2 all human resources, or let's put department of the hair department. But now when they come together, they're going to share information. So here we have blonde hair. We want to make blonde hair to the people, and here we want to have a black hair to the people. So they are going to combine information, and the result of this combination is you, is me. So this chromosome is coming from the papa, from the mama, and all this result is you. We okay with that?
Yes.
Yes.
Yeah.
Yes.
Okay.
Yeah.
Okay, you make me sweat because it's not easy to explain this. Okay, so now here we have the locus. Locus is the position of when we're talking about a singular and only one chromosome at a time. The locus. The locus, where is the department of hair in that building? So building A, building A, okay, excuse me. Excuse me, give me a second, please. I cannot. But I'm sorry. I apologize for this. Just a moment. Okay. So locus is the gene position that is gene is the codification for a protein. So for example, the color of your eyes, the color of your hair are going to be determined by the genotype of a gene. That genotype are going to show as a phenotype what you're going to see with your bare eyes. Is that clear or no?
It's clear.
Okay.
Yeah.
Alleles, thank you. Alleles are going to be two locus. What we don't call two locus, we call allele. When you compare the locus of the mother for the hair department and the locus of the mother, then the father for the hair department, and they are going to combine. The combination is going to be, as a result, you or me. Okay, alleles. Homologous chromosomes are going to be, for example, you compare two different chromosomes. Chromosome. This is the one who contains the hair department. This is the father. And here we have another chromosome with a hair department of the mother. Okay, so these chromosomes are going to be the same number. For example, chromosome 1 and chromosome 1, for example. And why we know it's chromosome 1? Because the characteristic of the size of the chromosome itself are going to tell us that that chromosome are actually comparable with the chromosome of the father and the mother. So you cannot put together chromosomes that are long arms and a chromosome like this, because these chromosomes are going to carry different departments. Department of the hair, department of the eyes, department of the skin, department of many other things, right? So you cannot compare these ones. So this is not happening. For example, this could be chromosome 1 and this is going to be chromosome 20, right? So there is no comparison there. So you cannot compare different departments. Departments of hair with department of the nails, you cannot compare that. There is no relation. So you need to compare with another chromosome of this is the father with the mother chromosome that contain the same department. And actually they have the same kind of shape of the chromosome. That's why we know how to pair chromosomes. Okay? Now, saying that the chromosomes that are comparable or equivalent from the father and the mother, they have the same departments. Those are called homologous chromosomes. Homologous, homo means the same. Okay, homologous chromosomes. And if you compare, that is not the case, we just name here, we are not doing that. When you compare one chromosome that is different from another chromosome, they have different departments. So those are heterologous chromosomes. Is that clear or no?
Yes.
Yes.
Okay, all right, thank you. All right, so
I have a question. I don't know. It's how did they? Sorry. So Monica.
Monica, go ahead, please.
Yeah. So I understand if they don't, then that's when you would get maybe, Down syndrome, or or there's 3 or 2 pairs that are, but how do they know to attract to each other? Like, oh, you look the same, you're the same trait or the same chromosome. How do they?
No, so that chromosomal mapping that you see there, this chromosome mapping that this one, you refer to this one?
Yeah, I'm just wondering how did they?
So okay, all right, so no, this is man-made because the chromosomes are going to be localized in different manners like this. And they are going to, yes, they are going to basically organize themselves in somehow. I don't know how they look for each other, but definitely they are going to. That's a good question. I never heard about that. I'm going to read that, Miss Monica. But definitely they are going to be not in this organized manner. They are going to, when I see that in the microscope, when I saw that in the microscope, we know that these chromosomes are located in the nucleus. Not nucleus because it's already in prophase. They are going to be in the organized manner. And for some reason, they get into pairs. They get into pairs at the moment of the metaphase. That is when it's happening. So we have chromosome, and these chromosomes are going to pair chromosome 1, chromosome 2 with 2, 3, 3, 4, 4, 5, 4, 4, 5, 5. The mechanism is, I don't know. I never look for that, to be honest with you. But
Okay, no, that's fine.
that is the
I was
way
just
that
wondering.
it happened. Okay?
Yeah, no, I was just wondering how they
No,
know to.
Just let's make a
Next.
follow-up. I will Google and I will look at my books how the chromosomes getting into pairs. So that could be the question. Okay. Anyhow,
Thank you.
sure. All right. So this is alleles. This is a locus. This is a locus. And when we are comparing, that is an allele. So when you talk about allele, you're going to have actually the comparison of two locus. Even though between the same chromosome, you cannot compare this locus to a locus of some gene here. You cannot. So they are going to be exactly matching one to another. Okay? Now, this locus is like you have a flavor, some flavor A, and this flavor B. So you mix the flavors, and the resultant is going to be you and me. Okay? Okay. All right. So talking about this, we already talked about the traits and homework here. How many of you have free earlobe? This is a free earlobe. Is like a hanging earlobe here, hanging earlobe, and here's a attached earlobe. Attached earlobe. This actually is going to be called dominant. And this is going to be recessive. Recessive. So what I can tell you about this is this. When you in one allele, when you have one allele, for example, you have black hair, department of the hair, black hair, and you have blonde hair here. So this chromosome is divided by this, okay? So like two branches here. So just to make it more real. All right, so here, and this is the father, and this is the mother. So they're going to combine, but what is black versus blonde? How is going to born the baby? The baby is going to result as a black hair. Black hair. Why black hair? Black hair, why? Because black hair gene is dominant over blonde hair. You want a proof of that? I want you to take your crayons and paint on a piece of paper yellow. Put yellow. Let me see if I can do. No, I can do. Okay, here. Yellow. That is blonde hair. And now I'm going to have black hair. Okay? So who is predominant, the black or the yellow? The black hair, right?
Black.
But tell me, the yellow is there? You have yellow in your genes? Yes, right? It's the
Black.
same. Yeah, the black is predominant because it's going to hide the
Yellow.
yellow. You okay with that?
Yes.
Yes.
For example, all right. For example, you can see me when I go to the school. my father, he has green eyes. He has very green eyes. My mother is brown eyes, brown eyes. So I have brown eyes, but on my behind on the same color is hiding the green eyes. You got it?
Yeah, that would be your genotype.
That
Versus
will
your
be my
phenotype that you
genotype
see.
that is going to
Yeah.
show a phenotype brown. Got it?
Yes.
Yeah. Got it.
Yeah.
Okay. So the same thing happened with blonde hair and black hair. Okay.
But if your mother would have had,
That depends on the grandparents. For example,
Okay.
If my grandparents will be having brown eyes, I have from my side father and my side my mother, I will be brown and brown. Brown and brown. So if I marry somebody who have green eyes, all of kids are going to be brown eyes. But if my wife will have green eyes, but brown eyes, hiding the green eyes, all of them are going to be brown as well, because I have dominant browns. All right, so I'm going to explain that later. So let's continue. So I'm going to explain that, and hopefully it's going to be clear. All right, so let's go to the attached ear. I want to see your ear. No, your ear is attached or detached? Oh, Kathy, show me. That is detached. You, Teresa,
I'm attached.
you attached?
Yeah.
Excellent. You are Rina. You are attached or detached? Show me. Put your ear in the camera. No, don't do. No, you have a earring.
Detached, doc.
Detached. Okay. You, Karina, detached. You, Julia,
Mine's attached.
attached.
Yeah.
Oh, okay. Daniela, you are attached or detached?
Detached.
Detached. You, Miss Monica,
Detached.
detached. And Nikki,
I'm detached.
detached. Okay. And Rachel, detached.
Detached.
Okay. So the ones who are having attached, I have attached myself. So I don't have detached. Detached is a recessive. And a detached, oh, sorry. I'm correcting myself. The detached is dominant. The attached is recessive.
Oh, you said it backwards. Okay.
You want the proof of that? How many of you was telling me you have detached? The majority, yes or no? Right?
Yes.
The majority. So that means that that gene is dominant.
Mm-hmm.
The rest are going to be recessive. So the attached ear is recessive. Okay? All right. All right, so let me try to explain this somehow. All right. Okay. So, all right, so now here we have, let's make it here. E is a gene, capital letter E for the detached ear, okay? Okay? And the lowercase lowercase e is the attached ear. So that is going to be, we are going to draw the lowercase always as recessive. and the detached are going to be the dominant. So now, if the father is going to have genes from his father and mother, right? The papa, the grandpapa, and the grandmama are going to have the son, right? And the son are going to receive, for example, E from the father and E from the let's make it E from the mother. So that is called homozygous dominant. All right, pay attention to this, okay? Father, so this is the father, this is the mother, dominant, 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 dominant. So what means homozygous? Please don't get confused with homologous and heterologous. Heterologous are the comparison between chromosomes, okay? We are not talking about that. Homozygous are going to be the genetic characteristic that is coming during the fertilization. Zygous means egg. So they're going to come together, and for example, father is going to have E and the mother is going to be E. Or it could be recessive. It can be another option, E and recessive of the mother. Or it could be another option, a recessive on the father and actually a dominant from the mother. And another option, you have recessive from the father and recessive from the mother. So there's different combinations that can happen. So in this case, you have homozygous because the spermatozoid and the ovum, they have exactly the same characteristic. So, my God, please, okay. Homozygous are going to be dominant. Okay, so here we have dominant, dominant. So the combination of these, the kid is going to have dominant and dominant. That is going to be homozygous dominant. Homo means same. Zygous means egg or cell. So the two cells, they have the same characteristic. E means E, capital letter, detached ear and detached ear. So the kid are going to born with the two genes dominant that are going to be called homozygous dominant.
Mhm.
In this case, the father, I make all the combinations possible. In this
Detached.
case, we have a dominant and we have a recessive. And this case, the kid is going to born with capital letter E and lower E. And that is called just heterozygous. Because heterozygous. Why heterozygous? Zygous, the egg, are going to have different color or different type of ear. This is going to be the detached and this is be attached. So they're different. So that's why it's called different zygous. This is very important. Then we have here, again, we have the recessive on the father and dominant in the mother. So that is going to be E again. And that is heterozygous. Heterozygous. That's it. There is no dominant or recessive in heterozygous. The word is just heterozygous, means different. The eggs are having actually different characteristics for the color of the hair or the type of ear. And here we have EE is going to be lowercase, lowercase. That is going to be homozygous because they have exactly the same. Homo means the same. Homozygous. Homozygous called recessive. Recessive. So you need just to remember two things. That in all these combinations are going to be possible homozygous dominant, homozygous recessive. And the other ones can be heterozygous. So there is three things you need to look at. Homozygous dominant, heterozygous, and homozygous recessive. So homozygous have dominant, means the two genes for that individual are dominant. Homozygous recessive means that the the two genes are going to have recessive, equal, but both are recessive. And heterozygous, it could be dominant recessive or recessive dominant. We don't call heterozygous dominant. We don't call heterozygous recessive. Be okay with that?
Yes.
Yeah.
Yes.
Yes.
All right, so let's go here, and I'm going to tell you. Tell me, from 4 kids, how many boys you think you will have? How many girls?
My parents had 4 kids.
Sorry?
My parents had 4 kids.
4 kids. So how many boys?
Yeah. 3 boys and 1 girl.
All right, so that is out of the rule, but definitely, yeah, it can happen. But you remember that actually okay, so let's do this. We have the
Is
female.
it 50-50?
The most common is going to be like this. Look at this, okay? So you remember I was telling you that in the population we have a ratio female and male 1-to-1.
Yes.
Yes.
Okay, so basically 1.01, so you in your case is going to be a slightly 1.01, so if the population will be like that, but basically we have 50% female and male. The sexual chromosome of the female is going to be X and X. The sexual chromosome for the father will be X and will be Y. So here is a combination. We are going to combine. My God, I'm going to kill this pen tablet. Okay, we are going to combine so combine here, X and X. XX. That is the first baby. Then combine X with this X, XX. Then combine this X with this Y, XY. And then combine this X with this Y, XY. So we have 2 boys and 2 girls. So that's why we have 1-to-1 ratio. There are some exceptions that happen, right? For the 3 boys and 1 girl, but the general and the most common is this. What I just described is the Punnett square. Punnett square. All right, so now let's make it more about what we was talking. Okay, let's suppose that you have blue eyes. Blue eyes. Blue eyes, I'm going to put it here, blue eyes are recessive. And in order to have blue eyes, the person needs to be recessive B and recessive B. Let's suppose that we have a brown eyes, but in my case, for example, I have a brown eyes, capital letter. Okay, so let's make it green eyes, okay? Green eyes. So you have green eyes, lowercase g, okay? Green eyes. So now the brown eyes will be like this. Brown eyes. If I have, this is dominant, but I have 2 options. I can have brown eyes that are going to be heterozygous. Brown eyes, that means it's going to be brown and green eyes. If I have homozygous, brown eyes, the only option is homozygous dominant. So in that case, I would have brown and brown. Now, if I marry somebody with green eyes, I'm here, heterozygous, brown, green eyes, I'm going to have, girl is going to be G and G green eyes, and male are going to be brown eyes and green eyes. So, and then I'm going to combine brown with G, with G with G, and G with G. So these are going to be green eyes. These are going to be brown eyes, but heterozygous because they have hiding the green eyes. You okay with that?
Yes.
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 Oh my God, I'm getting without voice. This is All right. All right, so let's do to the blue eyes. Blue eyes are going to be B and B. Brown eyes, that is, what is called this? Homozygous what?
Homozygous recessive.
That's it.
Homozygous recessive. Very good. And here we have brown eyes, and we are going to have this option. What is this? Homozygous,
Homozygous dominant.
homozygous dominant. And another brown eyes possibility are going to be B and B, yes or no?
Yes.
Right?
Yes.
This is going to be, how is called that?
Heterozygous.
Heterozygous.
Heterozygous. Okay? So let's now have a combination of these guys. B and B with brown eyes. That is the homozygous dominant and the homozygous recessive. So if you have blue eyes, you cannot have other option, the homozygous recessive, because the blue is very recessive. Okay? If you put B, for example, here, capital letter B and lower B, the brown eyes and blue eyes, is going to show brown because blue is recessive. Okay? So here, in this case, the patient is going, the phenotype is going to be brown eyes, dominant. And here we have blue eyes, recessive. So you combine, so let's suppose one female, a woman with blue eyes and a guy with brown eyes. And you're going to have here this combination. So here we have, all of them are going to be brown because dominant. But all of them are going to have recessive blue. One condition I want you to remember, when you're going to write down the Punnett square, always write down the capital letter. Always write down first the dominant or the capital letter. We okay with that? Otherwise, we are going to get confused. Okay? So I'm going to B and B, B, B. All right. So now let's suppose, now here we have all of them are going to be brown eyes. All brown eyes, 100%. Okay? All right. So now let's make it the blue eyes mother with an heterozygous blue with brown. Brown and blue. So what you're going to put here, capital lowercase, capital lowercase, 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 lowercase. Okay? So what is the result about this? We have 50% are going to be brown eyes and 50% are going to be blue eyes. So this is going to be homozygous recessive, heterozygous, and heterozygous. We okay with that?
Yes.
Yes.
All right, so let's go to the ears. Okay, so this is already written there. So, for example, dominant is homozygous dominant. Lowercase, recessive, homozygous recessive. What is different here, difference, are going to be heterozygous, period, nothing else. You okay with that?
Yes.
Yes.
Okay.
Yes.
Blood, we are going to talk about next class. All right, so you can read that. For example, here we have Plácido Domingo and Carreras, very, very kind of famous. So they have a different pitch of very similar, by the way, but they can make different pitches of frequency of the voices. And all they're combining voices. So you combine one voice here in one way and the other voice in different way, but when they're putting together, they have a unique sound. Yes or no? Right?
Yeah.
So that is the combination between the genes. All right, so we have dominant allele and we have recessive allele. So let's make a real here. Here's a comparison. Mix light blue color with dark brown. Will still appear brown. So remember I was telling the crayons and all that. Brown dominate over light blue. Brown eyes B capital letter is dominant and blue eyes is lowercase b. When both alleles are present, are going to be these together, brown and blue. So the brown overshadows the blue, and the brown colors the eyes is what you see. Even though the blue is there, it cannot be seen behind the darker or more dominant brown. Is that clear?
Yes.
Okay.
Yeah.
Okay, so let's go to the ears. Okay. This is the attached ear and the free earlobe. Okay, so let's make it here. All right, so first of all, let's go this. If X, capital letter X, is dominant, capital is dominant, allele, and X, lowercase, is recessive, coding for trait X, for example, color of the hair, then which of the following is true? Is going to be, if they combine, they're combined with X and lowercase, correct? Yes or no?
Yes.
Yes.
So the option is, are going to be dominant both is considered a homozygous recessive genotype. Homozygous recessive this is not right.
False.
No.
Capital letter is false.
It's like dominant.
Lowercase, exactly. Lowercase x is considered homozygous dominant genotype. True or false?
False.
False.
Heterogeneous, capital X, lower x, is considered an heterozygous dominant genotype. True or false? False.
False.
Because
False.
when you say heterozygous, you said heterozygous, period. You don't say, you do not say there does not exist heterozygous dominant, heterozygous recessive. It's just called heterozygous, period. The X capital letter, lowercase x, is considered heterozygous recessive genotype. True or false?
False.
False. XX, so we have here the combination that results on this. Dominant and recessive is considered the heterozygous genotype. True or false? That
True.
is true.
True.
Okay, so let's go to the ears.
Heterozygous, yeah.
Sorry?
Yeah. Sorry.
Okay, let's go to the ears. So there's two types of earlobes. People have attached on the bottom and free hanging or detached. All right, I'm going to go about detached or free hanging and attached. The free hanging, this detached, is called as dominant allele. So this is detached is capital letter. And the attached earlobe is a recessive trait. We are going to call lowercase. You okay with that?
Yes.
Okay.
Yes.
Now, based on that information, homozygous dominant genotype will be what?
A. E.
E, right? Because homozygous means father and mother have a dominant. Homozygous, homo, the same.
Mhm.
It somehow has attached earlobe, that is the recessive. You can guess that that their genotype is no, and yes, correct? Even though, look at this, if they have the recessive here, but it's overshadowed by the dominant. So it's not going to be attached, it's going to be detached because of this dominant. The only way they can be attached are going to be lowercase. Okay with that?
Yeah.
Yes.
So someone with genotype E capital letter is detached, and here E lowercase is attached. So how is going to be the phenotype here? Are going to be detached or attached?
Detached.
Detached.
Right? Because the capital letter is
Oh,
dominant.
and dominant and recessive.
Exactly. That is how we are doing the Punnett square. Okay. Oh my God. Okay, let's see. Draw the Punnett square to answer this question. If mom genotype is AA, okay? And that genotype is AA. I'm going to put it AA. Okay? The possible outcome for the children will be, write down first the capital letter, AA. Capital letter first, A. Capital letter first, A. Capital, well, there's no capital letter here. A and lowercase. So you have AA, capital, lower, capital, lower, lower. That is that. Okay?
Yes.
Yeah.
All right, so mom has attached earlobe. So that means that you have EE, correct?
Yes.
Yeah. And father have detached earlobe. Because they have detached earlobe, you have two options, EE or EE. Are you okay with that?
Yes.
Yes.
Knowing that that is heterogeneous zygote, heterogeneous genotype, heterozygous. Heterozygous is this one or the second one?
Second one.
The second one.
Second
This
one.
is the one. Why? Because they tell you heterogeneous genotype. Figure out mom's and dad's genotype and use the Punnett square to predict what will be the resulting genotype of their kids. So we are going to combine lower, dominant, recessive.
Dominant recessive.
So write down first of all the capital letter, right?
And
All right,
EE.
is we okay with that?
Yes.
So
EE.
EE,
Yeah.
EE. Capital lower, capital lower, capital lower. Lower. That is the answer. But you need to remember what is the difference. If they will say homogeneous, you will select this one instead of this. Yes or no?
Yes.
Yeah.
All right. Excellent. Now, based on the question 2, what is the percentage of offspring that will be attached earlobe? Attached earlobe.
50%.
50.
Mm-hmm. Half.
So it'll
Attached
be
earlobe. Attached earlobe, what you are looking, attached earlobe is the EE, correct? Lower, correct? Yes?
yes.
Yes.
How many of 4 you have? 1 and 2.
2.
We have 50% chances to have attached ear.
Mm-hmm.
Okay? In both parents, listen, both parents have detached earlobe. Both parents have detached. So they can be E or EE, correct? Or EE. I'm going to write this one down. Okay. Both parents have detached earlobe. So they can have EE or EE, correct? Yes or no? For both. And both are heterozygous. So which one you select? The first or the second?
The
Second.
second one.
Second. So, and then you're going to do the Punnett square. You go E, because both are heterozygous. So you have capital, lower, lower. So the answer will be this. Capital, lower, lower and lower.
Mm-hmm.
You okay with that?
Yes.
Yeah.
Okay, so now, question number 5. Based on question 4, what is the percentage chance that the offspring will be attached earlobe? Attached earlobe, that is basically a recessive, right? It's going to be E and E, correct?
Yeah.
There is no other option, right? This is homozygous recessive. So the only one is 1 here. So we will have that only 25%. Okay?
Yeah.
25%. One parent is homozygous dominant. We are talking about ears. One parent is homozygous dominant. That means E and E, correct?
Yes.
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 Okay? And the and the other is homozygous recessive. That means E and E. Yes or no?
Mm-hmm.
Then the possible offspring will be E and E. Doesn't matter if you put the father or the mother here. Doesn't matter. Okay? So as long as you do that combination. You have capital letter, lowercase, capital letter, lowercase, capital letter, lowercase, capital letter, lowercase. And you will have the same here. Okay?
Yeah.
Based on the question 6, I got this perfectly. What is the chance for the offspring to have attached earlobe? Attached earlobe means that you need to find somebody who have lower. Attached ear, because attached ear, the only option is to be homozygous recessive. And none of these are homozygous recessive. All of them are heterozygous. And that is 0%. Yes or no?
Yes.
Yeah.
Yes.
Answer, 0%. Okay? Phew. All right, so what time is it, please?
8:42.
Okay. My God, 2 minutes different from the previous class. Okay. All right. So mom is homozygous recessive. Homozygous recessive. So what is this? Homozygous recessive, and that is dominant, is homozygous dominant. Okay. So that is talking about having blue eye, right? Homozygous recessive is going to be mama blue, lower. And that homozygous dominant, brown. You can be black, whatever. So what you're going to have, how many blue eyes you have? Capital lower. How many blue eyes we have here?
Neither.
0.
0%. You got it?
Yes.
Both parents are heterozygous. What are they called? Heterozygous. Heterozygous is going to be, for example, brown and blue. Brown and blue. Yes or no?
Yes.
Yes.
Combine dominant, capital lower. So from out 4, I have only one that is blue eyes. So that is homozygous recessive, right? They're going to result as homozygous recessive. And that is basically 25%, 1 out of 4. Okay? Mom have brown eyes, and that blue eyes. Baby have blue eyes. What is everyone genotype? And that is a little bit more elaborate. So here we have mom have brown eyes. Brown eyes will be brown, or could be brown, blue, correct? And that have blue eyes.
Yes.
That is going to be B and B. You already know that if you combine with these, all of them are going to be brown because there is a dominant always. So the combination should be between this and this, heterozygous and homozygous recessive. And you're going to have B, and the other B. So you have capital lower, capital lower. So you will have 2 kids who has blue eyes. So capital lower, capital lower. We have capital lower, lower. Okay?
Yeah.
Yes.
All right, so let's talk about hemophilia. And that is going to help you to understand. We have hemophilia and codominance. That's only 2 things that we need. So, all right, so we have time. Excellent. All right, so hemophilia. Okay, I'm going to give you a little bit extra here. We have the liver. The liver, you know, they have functions. So A, B, C, and D, correct? A, the albumin. B, the bile. D, the detoxification, ammonia, right, and urea, and the coagulation factor. These coagulation factors are proteins. Proteins means genes, right? Yes or no? Right?
Yes.
So here we have, in order to produce the fibrin, that is the product that is used for coagulation, you need to have 12 reactions. Reaction 12 to reaction 11 to reaction 10 to reaction 9 to reaction 8, to reaction 7, to reaction 5, to reaction 4, to reaction 3, to reaction 2, and reaction 1. This is the one. Reaction 1 is the fibrin. So all of these are proteins. So you need to, in order to produce this fibrin that is part of the coagulation process, very important, where it's happening inside the liver. So there are proteins. Each protein represents a gene. Proteins are genes, all right? Represent a gene, are not genes. The proteins represent the decodification of a gene. Now, in order to have fibrin, you must have from 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. But if one of these is absent, in this case, hemophilia is not protein 9, the Hageman protein, the reaction to produce fibrin is going to be 12, 11, 10, and stop. They cannot jump to 8. They cannot jump to 7. They need to pass for 9, but 9 protein is not exist. You okay with that? And that is going to produce actually problems for bleeding. So risk for bleeding. So these people can die from bleeding. For whatever small injuries are going to bleed longer time, and that can lead into death of the patient. Where is this gene located? This gene located for hemophilia, the gene located for hemophilia are going to be in the chromosome X chromosome. Now, in order to name the chromosome with hemophilia, I'm going to put it here, X with H here. You okay with that?
Yeah.
Yes.
Okay. So now a female, you know, hemophilia most commonly happen in male. In male, we have most commonly hemophilia, not in female. Why? Because a female, when they have the chromosome hemophilic X, the female have another chromosome that is going to compensate the other chromosome. So in this case, the female do not show disease, but is a carrier. Is that clear or not?
Yes.
Clear.
Now, this woman who is a carrier, I'm going to put it here. This woman is a carrier, correct? But doesn't show disease, correct?
Yes.
Yes.
And is going to be married with a man who doesn't have hemophilia. So you have always write down first the dominant, but in this case, you're going to write down always the disease, XH. XH with X. X and X. XH and Y. And X and Y. If women is a carrier for hemophilia, you have 4 kids, you have 1 female normal, 1 male normal. We have 1 female, a carrier, doesn't show the disease, but 1 male is going to show disease. Why? Because we don't have another X to compensate. We have instead of that a Y, so they cannot compensate. And in this case, we show the disease. Is that clear or not?
Yes.
Clear.
Yes.
Oh my God, you look more okay. I'm going to ask a question that I asked in the morning. I don't know why. I put more effort on the eye, but anyhow, all right. All right, with your choice. All right, so we have here a female. All right, so let's make some exercises. So here they put M, but I don't want to put N because it's confusing. So just put X alone, that is normal. You okay with that?
Yes.
Yeah.
All right. So this XX will be XX, that is healthy female. XH with X, always write down the pathology first, are going to be a carrier of abnormality, but a healthy female. Do not show the disease, but it's a carrier. And female are going to be XX. So in the morning, you're going to ask me most likely, if there is hemophilia in female. Yes, there is hemophilia with female. And we are going to check you that in a few moments. All right. For example, you have XY, that is a male that is normal, healthy. But you have a male, XHY, that is with hemophilia. You okay with that?
Yeah.
Yes.
All right. So now let's make the combinations. The combination will be a female that is a carrier with a male. There's other male is going to have the disease. Okay. All right. So now carrier female is going to be XH and X. A male disease are going to, let's make male normal first. Male normal. Male normal is going to be XY. So you're going to do here probably I didn't put it right here. Okay. Female carrier and male healthy. And this case, you're going to have XY. So you have XH female, XY of the male, and that is going to be XH with the X here, XX with here, XHY, and XY. So a female, think about a female, you're caring for hemophilia. Well, you're okay. I don't have any symptom. I'm a carrier. Your husband have some problem with, no, it's normal. So I would say, how many kids are going to have with hemophilia? So here we have a carrier. A carrier do not show disease. This is totally normal. This is actually hemophilic because you have the XHY. This is a Y, cannot compensate. So they show the disease. And this is normal again. Normal, normal. And that is a carrier. So they are going to ask you, how many carriers are in the kids? Chance we have 1 every 4. So 25% chance to have a carrier. How many chances to have normal? For all kids, I have 50% normal. Normal. 2 out of 2 out of 4. How many kids I can have a risk to have hemophilia? 1 out of 4, 25%. Now, if they ask you in different way, from my girls, if I have a girl, my girl have a chance, just talking about girls, are 2 girls, right? 2 girls. From these 2 girls, how many are going to be having a disease? None, 0. How many are going to be carrier? 1, 50% of the girls only. And 50% of the girls are going to be normal. In males, if I have a boy, so mother is a carrier, the father is normal. What is my chance that my boy is going to have hemophilia? From all my boys, out of 2, I have 1. So 50% of boys are going to be hemophilic, and the other 50 will be normal. You okay with that?
Yeah.
Yeah.
Yes.
Okay. The other option will be that the male is having what? Male is having hemophilia, and the mother is a carrier. So we are going to have HH, X, XH, Y. So we have XH, XH, the first one. XH, first the pathology, and X. We have XH and Y and XY. So from all the kids, how many boys are going to have hemophilia? How many kids are going to have hemophilia? 2. Because here we have a girl who has hemophilia. Both eggs are going to be affected with hemophilia. There is no normal eggs that compensate. So in this case, girls are going to have hemophilia, but the most common all over are males because they cannot compensate. So when is that happen? When the female is a carrier and the male is having a disease. father have a disease, hemophilia, and the mother is a carrier, you will have a girl who have hemophilia and a boy who have hemophilia. You okay with that?
Yes.
Yeah.
Yes.
Okay. What other option we want to have? All right. Let's suppose that the female is having hemophilia. Okay? And let's suppose that the male is normal. Imagine a case. Female hemophilia and the male are going to be healthy. So we have hemophilia, X and Y. So we have X, hemophilia X, this is a carrier, right? Then we have here the pathology first, and then X, this is a carrier. Here we have the X, H, and we have Y, this is hemophilic, and we have X, H, and Y. So we have hemophilic. Oh, sorry. They're going to be hemophilic. You okay with that? So if you have a female with hemophilia and a male that is normal, all your boys are going to be hemophilic. And all your girls are going to be a carriers. So listen to this. Some questions are asking about boys only. So these two are going to be your 100%. But if I ask you general for all the kids, the 100% will be 4 of them. You okay with that?
Yeah.
Yes.
Yes.
Okay. All right, so some exercises we are, oh, by the way, that is actually the color blindness. The color blindness are going to be like this. I'm going to put C here. And this is a female. So this is a carrier, color blindness. It's the same exactly situation that happened with hemophilia. You okay with that?
Yeah.
Yes.
Okay. Now you understand why it's most commonly in male than female. Now, to let me know that you are not color blindness, you need to tell me which number you see here. If you don't see a number, you're color blindness. Tell me. Who is color blind? Hello? You don't see the number there?
I'm not supposed to be colorblind. I don't see any number.
And it's all black.
Oh, I'm
With
sorry.
dots.
I'm sorry. I made a mistake. This is the one.
Green and different colors. Yeah, it's green.
Yeah, now I see a number.
Yeah. No, the previous one was just trying to trick.
You freaked me out. I was
You're
like,
a
what?
little bit there, Dr.
Okay.
74?
That is 74. Yeah, you are. And the last thing we are going to talk is about the codominance. What time is it, please?
8:59.
Okay, the codominant, 30 seconds. The codominance is when two genes are dominant together. And that is basically we are going to talk about. Can you give me 5 more minutes, please? Okay, all right.
Yeah.
So the codominance is, for example, in plants. In plants, you have plants that are red color and other plants that are white. White and red, each of them are dominant. Okay. Now, when you make, how you call when do you put one stem with another stem? How you call that?
Sexual reproductive.
Huh?
Reproductive.
No. Well, there's a name. Graft. There you go.
Grafting.
Grafting, right? When you put grafting of red color flowers with white color flowers, the flowers are going to appear like this. One group are going to be red. Another group are going to be white. Oh my God. I hope it's okay. And the other group is going to be pink. Because both are dominant. So that is the codominance. So when both genes are going to refer as a phenotype. All right, so the last thing, Diana, you have brown eyes, brown eyes, brown eyes, but you don't know if your brown eyes is dominant or homozygous or dominant heterozygous. Heterozygous, what we're talking about. Oh my God. So you have brown eyes, you don't know if you have homozygous dominant or heterozygous, but you have brown eyes in both cases, right? So how do you suspect you have heterozygous when your grandparents are having green eyes? If one of your parents have green eyes, you have a recessive green eye. So that means you are heterozygous brown. Make sense or no? So,
You mean Daniela,
Okay.
right?
huh?
Daniela, not Diana.
Oh, Daniela, sorry. You know, I'm very bad with names. I apologize. I'm embarrassing me. She's laughing at me. Okay, that's okay. That's okay. All right, so now, if, for example, I have brown eyes, but I have brown, but my father is green eyes. So that means that I'm not homogeneous dominant. I am heterogeneous, brown green eyes, correct?
Yeah.
So now, if I marry somebody who have green eyes, I have a chance that my kids have green eyes. But if I will be homozygous dominant or brown eyes, all my kids, if I marry blue eye, green eye, red eyes, whatever, all of them are going to be brown eyes. Okay?
Yes.
Okay.
Yep.
Rachel, how do you feel about the class? I cannot hear you, dear.
Sorry. It was interesting. As usual, the examples help a lot. And I learned that vitamin A helps for like revision if
Okay.
you can't.
Please
So that,
apply that at home, okay? Apply that at home. So
yeah.
check the ears of your family, check the ears, the eyes, try to find out the genotype, the phenotype, okay?
Yeah.
All right. So Julia, what is your opinion about the class? What is your comment?
I think it was a really good class, and it's interesting to learn about like for those of us that don't have kids, if we ever want to have kids, what might happen to them or what kind of genetics they might come with.
Okay, excellent. Thank you so much. Any suggestion to improve or to do better, or you can talk about tutoring and all that. Yes, or anybody who can give me any idea, I will really highly consider it. Please, Karina.
It's just a little overwhelming with the information, but the repetition of vocabs and samples and the illustrations really help. So far everything's okay.
Okay, thank you. Miss Nikki. Okay, Nikki. Everybody listen, please. Nikki's talking.
It was really great. I really appreciated all the examples, like when we were talking about in regards to the aqueous humor, like you talked about how like when we cry or when we should put eye drops in or when we have a sty. And then I appreciated you also going through all the practice questions because it made me learn better that way. Thank you.
But anything we can improve, let me know, please. Okay? All right? Miss Monica, please.
No, I have to agree with Nikki. I did like the examples and using like the life lessons that you've already have experienced and, little quick things to learn, like the eye drops. That was interesting. Bill Rubin, when, in babies, because we're just used to it. We don't really understand the process or why we do it. We just do it. And then I like the questions because, you go over it and then it makes me think, okay, if it's not this, then would it be this? So, and then that's it. I'm glad you did the I first because that helped me. I was wide awake here. I was kind of, it's like, okay, I got to rewind this. So,
Okay.
but
Okay.
everything was fine. Thank you.
All right. Excellent, Miss Monica. Any suggestion, please let me know. Miss Daniela, please.
It was really fun. I was thinking of my family and my siblings, the ones that have light eyes versus brown eyes, and also my son. Like wondering, like knowing where it came from. It was really fun.
Okay, excellent. You practice at home. Okay, check the eyes, check the ears of the people around. Home. Miss Rina.
Overall, doc is like good, and as I've said like a while ago regarding the vitamin A, so I know already. I know now that I have to take vitamin vitamin A in order for me to see clearly at night.
Excellent. Very good. So apply that at home, please. Everything that you learn, this is the best way to learn applying at home. Okay. Thank you so much. Mr. Tong, please.
It was good. I like the topic. It's actually like it's just something that we use every day. So it's actually very interesting. So and it was actually a fun lecture.
Excellent. So if you have any suggestion to improve and all that, please let me know. Ms. Teresa, please.
I really enjoyed the lecture. I really like doing Punnett squares. I think they're so fun, and they're, but I never did like a hemophiliac one, so that was really cool to find out. Because there's actually two students, both males, at my school that are hemophiliac, so I can kind of think about that.
Excellent. Well, no, I'm sorry to hear that, but yeah, you have the knowledge, and that is help you to understand the situation, and you are going to be a nurse, you're going to be a leader, and any problem in society, the first line, they're coming to the nurse, and you are prepared for that. You're preparing here for that. Thank you so much, Teresa. If there's any additional thing I can do or we can improve, let me know, please. Think about it, please. Miss Kat.
I also have to agree with Teresa. I really like doing Punnett squares, but I've never done one with like a genetic disorder. So I thought that was really cool to actually go through that and see. So yeah, and I appreciate you taking the time to go through a bunch of those practice questions with us. That was really helpful.
Tell me, Kat, would you like more the eye or the genetics?
I mean,
Tell me.
They're so different. So I always really like the anatomical things. I don't know. I mean, it's to compare anatomy with physiology is different.
Teresa, which one do you like more, the eye or the genetic? What do you enjoy more? What did you enjoy more, the genetics or the eyes?
I enjoyed the genetics.
Genetics? Tom, you?
Yeah, I agree with Teresa.
Rina, you? Yeah, very good, Mr. Tom. Oh my God. Rina, what do you like, eye or genetic?
Both, doc.
Okay, thank you. You, Daniela?
I enjoyed the genetic a little more.
Okay. You, Monica? Monica, I didn't hear you.
No, sorry. I like the I.
Eye, excellent.
Yeah.
Nikki, please, everybody listen.
I liked both, but maybe the eye more.
Eye more? Okay. Karina?
Both are interesting. It's just, yeah.
Julia?
I liked both. I think the eye was a little less complex, so but I liked both.
Okay. And you, Rachel? Rachel?
I already answered, but yeah, I said I liked everything. Sorry, my phone died. So.
All right, so definitely I put same effort, but I is more my stuff. but genetics is very interesting too. Very interesting.
Mhm.
We are going to do math on Sunday. Okay.
Mhm.
Everybody's a little bit tired already, so let's do math on Sunday. Okay. All right. At what time we are going to do at 8 o'clock p.m. Okay. All right, guys. So I hope that you enjoy the class as much as I enjoy it. And any questions, please, just call me or let me know, text me. I will actually answer as soon as I can. Okay? Okay, muchas
Great.
gracias. Muchas gracias. Thank you so
Thank
much.
you.
Thank you.
Thank you.
Good night.
All right. Good night.
Thank you. Buenas noches.
Buenas noches. Nikki,
Hello.
tell me, you want to tell me something? What happened?
Wait, don't I have to redo the quizzes?
Review quizzes?
Yeah, remember you called me
Oh, yeah,
yesterday?
yeah. Just a moment. Just a moment.
Okay. Or I could do it tomorrow too.
Yeah, let's do it tomorrow because
Okay.
I'm exhausted. So
Okay,
I'm
me
going
too.
to
Yeah, you're tired. You're
review your
tired.
grades, and yeah, you was working. I remember.
Yeah,
Yeah,
sorry.
yeah. So all right, so let's contact me about 6 o'clock tomorrow p.m.
Okay, but so again, like I don't get off till 7:30 and I get home at 8.
All right, so
So the earliest I could do is
let's do
8.
it at 9 p.m.
Okay.
But you call me, please.
Okay, yeah, I'll call you.
Okay, just to
Okay.
to make it even everything, and just to think about your last weeks for bioscience.
Okay,
Okay.
got it. Thank
All right,
you.
thank you.
Have a good night.
Good night. Good night.